Welcome everyone to our National Visceral Anatomy Seminar. The aorta is the largest artery in our body. It's also the strongest, yet it's one of our most vulnerable. I'm very excited to introduce today's topic as abdominal aortic aneurysms, or AAA for short, where we will be going into a very interesting case that I was once involved in. I have the privilege of being joined by all these wonderful doctors today who can't wait to share their amazing insight. Let me introduce you to today's case. The patient was a 65-year-old white male with a history of smoking and alcohol use. He presented with increasing abdominal pain, nausea, and an expansile pulsatile mass on his lower abdomen. I'd now love to hand it over to Dr. Fu to get us started.
Thanks, Dr. Prabhu. Just to give some background on AAA, approximately 4.8% of the general population has it, with greater prevalence in Western countries than in Asian countries. In addition, AAA is most prevalent between the ages of 65 and 74 years old, with no cases found below the age of 50 in both sexes. However, the prevalence does increase with age. It was also noted that after the age of 70, AAA increased significantly only in men. To add to that, AAA primarily affects men who make up 1.3 to 8.9% of the total reported incidence, which is 5 times greater than in women, who make up only 1 to 2.2%. However, the rate of rupture is higher in women, with 1 in 3 patients with a ruptured AAA being female. Furthermore, the information presented above makes light of some non-modifiable risk factors which contribute to the incidence of AAA, that being age, sex, and race. However, there are modifiable risk factors too. These include hypertension, smoking, coronary artery disease, dyslipidemia, claudication, and renal insufficiency. One exception is diabetes, which surprisingly doesn't contribute to AAA incidence at all. I will now hand it over to Dr. Prabhu to talk about how this disease develops.
Thanks, Dr. Fu. So as mentioned, the aorta is the largest artery in our body and carries oxygenated blood away from the heart for its distribution throughout the body. The abdominal aorta is its last part and commences at the T12 vertebral level, passing by the aortic hiatus in the diaphragm, terminating at the L4 vertebral level, whereby it bifurcates into your common iliac arteries. A AAA is a permanent localized dilation associated with a diameter larger than 3 centimeters, where it is 1.5 times its usual size. AAAs can be further classified into suprarenal, involving visceral arteries such as your splenic, hepatic, or mesenteric arteries, pararenal, involving the origins of your renal arteries, or most commonly infrarenal, below the L2 level where the renal arteries originate. AAAs are due to change in the integrity of the aortic wall, from a strong elastic wall to a weak, rigid wall with less elasticity, which is unable to deal with the high pressure of the circulating blood. The main causes of a change in aortic wall integrity include atherosclerosis, which is a buildup of plaque in the inner lining of the artery, calcification in the artery with age, and chronic high blood pressure due to the thickening of the tunica media, which is the artery's middle layer. Other more rare causes include bacterial or fungal infection in the aorta and involvement in a car accident, which can cause trauma. Whilst current literature currently describes the causes of aortic weakening, there still remains literature gaps, whereby the underlying pathogenesis and the mechanisms of a AAA remains unclear. The tunica media also contains proteins such as collagen, which gives strength, and elastin, which provides recall to the artery. As you descend further down the aorta below the level of the kidneys, the amount of collagen and elastin are decreased, especially with age. Thus, this contributes to the weakening of the wall and associated bulging. The increased tension within the wall will lead to further dilation of the artery and hence enlargement of the aneurysm. That just about sums up the disease process and its anatomical basis, but I'd now love to hand it over to Dr. Perrin to take you into the clinical presentations.
Clinical presentations are usually absent during the development of an abdominal aortic aneurysm. Only when the aneurysm expands close to the point of rupture, there is a triad of presentations that are indicative of an abdominal aortic aneurysm. There's hypertension, which is low blood pressure from the lack of circulation likely due to rupture, a pulsatile abdominal mass, which may be felt due to the expansion of the aneurysm, placing high pressure on the vessel wall, and abdominal or lower back pain due to either the aneurysm eroding into the lumbar vertebra, an increase in vascular wall pressure, or vertebral scalloping. These factors assisted the radiologist, Dr. Azan's diagnosis of a AAA.
Thank you, Dr. Perrin. We use unenhanced CT and CT angiograms as they allow for multiplanar analysis and the relation of the aneurysm to other abdominal vascular structures, which allowed for preoperative planning. Since the patient did not have renal impairment, the use of IV contrast was not contraindicated. For general AAA screening, we use the ultrasound because it is cheap, there's no ionizing radiation or IV contrast, and it's fast. So the scan showed signs of an abdominal aortic aneurysm with impending rupture. Let me show you how I came to that finding. In this lower abdominal axial CT angiogram, the red line shows that the maximal diameter of the aneurysm is 12.5 centimeters. The most common predictor of rupture is one that is larger than 5.5 centimeters or has grown more than 0.5 centimeters in the past 6 months. Non-ruptured aneurysms have more thrombus than ruptured aneurysms, as it is believed that a thick circumferential thrombus is protective against rupture, as can be seen by the blue line, and is probably why this very large aneurysm had not ruptured at the time of the scan. This upper abdominal axial CT angiogram shows involvement of the renal artery. Unenhanced CT scans prove to be valuable when looking for the hyperattenuating crescent sign, an initial sign of rupture, as seen by the white arrow in this axial abdominal unenhanced CT scan, with an acute hematoma in the aneurysm wall. It is indicative of dissection of blood into a peripheral thrombus or into the aneurysm wall, and usually means that the aneurysm is unable to protect itself from rupture. Now, Dr. Perrin will tell you about the fate of this impending rupture.
When we identify the presence of a AAA, we need to be aware of the complications. Rupture occurs when the force per unit area within the vessel exceeds the tensile wall strength. Rupture of an abdominal aneurysm can cause blood to flood into either the peritoneal cavity in 20% of cases or into the retroperitoneal cavity in 80% of patients. The patient case experienced a retroperitoneal rupture during surgery, which caused fatal internal bleeding. However, internal bleeding into the peritoneal cavity is actually more fatal due to the lack of tamponade effect and the loss of entire circulatory volume. More complications could have arisen are focused around infarction due to thromboembolism. If a piece of mural thrombus overlying the aneurysm enters the circulation, it becomes a thromboembolism. If a thromboembolism becomes lodged in a cerebral artery, there is restricted blood flow to the brain, producing a stroke. If this occurs in the coronary artery, it causes a myocardial infarction. Dysfunctional myocardium can also produce ventricular arrhythmias, which can be fatal. There are many other complications that can also arise from an abdominal aortic aneurysm, including limb ischemia, kidney failure, gangrene, which can lead to amputation of the limbs, and autoenteric or autocavale fistulas. The case patient presented indications for surgery, which was unfortunately unsuccessful. However, the surgeon, Dr. Mani, will outline the details.
Thanks, Dr. Perrin. So the main aim of treating abdominal aortic aneurysms is to prevent rupture and its associated high mortality rate. Current treatment options unfortunately only consist of surgical repair and rely heavily on the size of the aneurysm to determine an appropriate time for clinical intervention and treatment, and this comes with many risk factors. For asymptomatic patients who do not present indications for elective repair, medical treatment is aimed at reducing the risk for cardiovascular events and the rate of aortic expansion. However, for asymptomatic patients who do indicate for elective repair, surgery of the aneurysm is the most effective form of management to prevent rupture. However, elective aortic repair is associated with high risks and thus is not recommended until the risk of rupture exceeds the risk associated with repair. In our case study, our patient underwent open abdominal surgery, also known as open surgery, which usually involves the surgeon making a large incision in the abdomen and clamping off the aorta above and below the aneurysm. The damaged section of the aorta is then removed and replaced with a synthetic tube called a graft. This is then sutured into place and allows blood to flow normally through the aorta as the artery wall is enclosed over the graft to protect it. However, unfortunately, in the case of our patient, the aneurysm did rupture shortly after open surgery, which is a high risk factor for open surgery. The recent development of a less invasive procedure called EVAR, or endovascular aneurysm repair, is a far more oftenly used treatment. It usually involves making an incision in the groin to expose the femoral artery, placing a wire in the vessel over which a variety of specialized catheters are then used to pass the folded stent graft through to the abdominal aortic aneurysm, where it unfolds and allows the blood to flow through normally. While EVAR does provide more short-term benefits than open surgery, it is important to note that it does not provide a quality of life benefit, improve long-term mortality, and is often associated with the need for for re-interventions and monitoring, and therefore carries its own set of complications. Therefore, possible future pharmacological interventions that decrease the risk for treatment are current gaps in our knowledge, and this is something that Dr. Howe will cover. Thank you.
Thank you, Dr. Manny. So many studies struggle to identify the underlying pathogenesis of abdominal aortic aneurysm, because the root cause of this condition is a large gap in our knowledge. Consequently, without accurate knowledge about the cause of AAA, there is no clear target that pharmaceutical drugs can manipulate in order to slow aneurysmal growth and prevent rupture. Instead, any drug that has been developed thus far can only target factors associated with this condition. For example, studies have collectively shown that novel drugs including statins, doxycycline, and cyclosporin have the potential to attenuate aneurysmal growth due to their anti-inflammatory properties that reduce inflammation associated with AAA. Unfortunately, since none of them have been proven to be an effective agent against AAA in human studies, there is yet to be a pharmaceutical drug that has been approved for clinical treatment. It is imperative that future studies continue to uncover the cause of this condition so as to provide a means to develop a pharmaceutical drug that will be able to replace invasive surgeries as a more effective form of treatment for abdominal aortic aneurysm.
I'm so sorry guys, but it looks like we're running out of time today. We all hope that you've enjoyed listening to everything that we've had to share with you, and that you have a better understanding of the things you can do to prevent or respond to a AAA. Thank you again, and we can't wait to see you all again at next year's National Visceral Anatomy Seminar with a brand new case as we continue our journey through the human body.